afternoon. My name is Pamela Gentry, and I'm the Acting Deputy Director for the Center at CMS for the Office of Minority Health. Thank you for returning to the Grand Plenary with us. It's wonderful to see all of you in the room here, and for those of you joining us everywhere electronically or virtually, or both. At CMS, our strategy to advance health equity will address the health disparities that underlie our health system through stakeholder engagement and by building this pillar into the core function of CMS. CMS serves the public as a trusted partner and steward dedicated to advancing health equity, expanding coverage, and improving health outcomes. As part of this work and to the support of the Administrator's strategic pillars, several cross-cutting initiatives were announced by the Administrator to support equity and additional work across the agency. One of these areas where the agency has looked to focus on is maternal health. CMS has been working on a coordinated maternity care strategy, seizing every opportunity to improve maternity care across the spectrum, quality, improve the health outcomes, and to reduce disparities. CMS will work with state, health care facilities, community providers, and other partners to improve the quality of maternity care, expand postpartum coverage, and support a diverse provider workforce. These efforts will reward high-quality care, expand access to coverage and care, and begin to address the health inequities that underlie our healthcare system. Today, we will hear from some of the key people working on CMS Maternal Health Care Strategy. Our moderator today will be Dr. Dora Hughes, Chief Medical Officer of CMS's Innovation Center. We'll also have Tequila Terry, Director of the State Innovation and Population Health, also of the CMS Innovation Center. Aditi Mallick, Chief Medical Officer of CMS's Center for Medicaid and CHIP Services, and Jean-Moody Williams, Deputy Director of the Center for Clinical Standards and Quality, better known to me only as CCSQ. So, ladies, please take the stage.
Good afternoon. Before I dive in, I just want to take a moment and acknowledge all of the amazing work that CMS Office of Minority Health has put into this amazing conference today, the speakers, the sessions. It really has just been fantastic. And it's so much our pleasure to be able to participate in this event today. I want to thank all of you who are joining to hear more about CMS's maternal health efforts. And the earlier panel today, CMS Innovation Center focus panel, I referred to our very large panelists as the Sensational Seven. And if I continue on with this superhero Marvel theme, and then I was like, well, then we are the Fantastic Four. You'll be able to tell from our presentations and our discussion how closely we work together. I would even note that we are even color coordinated, all in pink, and I don't want you to think that that is by accident. So in terms of our panel, at CMS, you've heard throughout the day, but it really bears repeating that equity is the foundation for all that we do at CMS. We want to make sure that our programs are operating to maximize health and reduce, if not eliminate, the inequities that underlie our healthcare system. That is why, as Pamela referred to in the opening, that's why, in part, we released our Comprehensive Health Equity Framework. It provides an integrated, action-oriented approach for CMS to advance health equity among members of our communities who have been historically underserved or disadvantaged. Overall, we're looking across all of our policies at CMS, as you'll hear, whether it's the Medicaid demonstration projects, or if it's our measures that we're using, if it's the diseases, conditions, the populations that we're targeting. We're looking across all of our policies through a health equity lens. But nowhere, perhaps, is the work more important than the efforts to address healthcare, health inequities in the area of maternal health. As our administrator, Chiquita Brooks-LaSure, often states, the health of our nation begins with the health of our mothers and the health of our children. And as we know, the United States continues to face a terrible maternal health crisis. Approximately 700 women in the United States die every year. That's 2 women every day on average. Die as a result of pregnancy and its complications. And over 80% of these pregnancy-related deaths are preventable. Despite all of the attention, this crisis is not abated. And in fact, our colleagues at the Centers for Disease Control and Prevention have reported that the situation is getting worse. The maternal mortality rates in the U.S. increased annually from 2018 to 2021 across all racial and ethnic groups. And the inequities remain shocking. Black maternal mortality rates increased by 40% from 2020 to 21. And black women the mortality rates are 2.6 times higher than white women. These racial disparities have persisted despite advancements in care and across all socioeconomic status, whether that's levels of income, education, marital status, where you live. And it really just helps to underscore how systemic inequities perpetuate and often exacerbate disparities. We're dealing with structural racism, implicit bias, social determinants of health, and variable coverage, access, and quality of care. And all of these collectively are contributing to the maternal health crises, especially among black women. I am proud that this administration has made preventing maternal mortality and morbidity a top priority, and especially addressing the inequities in maternal health. We have made it a whole of government priority, and CMS is certainly doing its part. With leadership by our administrator, Chiquita Brooks-LaSure, CMS released a maternity action plan, which is really designed to support initiatives to improve health outcomes and reduce inequities for people during pregnancy, during childbirth, postpartum period, and really utilizing a holistic and coordinated approach. Our maternity action plan focuses on 5 areas, and we're going to touch on each of those throughout this panel today. First, we're working to expand coverage and access to comprehensive health care through all of our programs. And 2, especially very important as you've heard about the unwinding, thinking about the transitions of care for before, during, and after pregnancy when families need it the most. Second, we're expanding our data collection efforts to build a better understanding of the key drivers of inequities that we've outlined. Third, we're improving the quality of care by working directly with health systems to increase the uptake of evidence-based guidelines. Fourth, and very importantly, as we're increasingly focusing on holistic whole-person care, we are building bridges between the care that CMS pays for and the social supports that are provided by other federal, state, and local partners, with the goal of providing whole-person care to pregnant and postpartum enrollees. And finally, fifth, we're improving access to a diverse maternity care workforce, including midwives and doulas and other community-based partners, by working with states and sister agencies to expand our workforce at every level. We are aware, I've talked about the disparities facing certain racial groups. We are aware that other populations merit special attention as well. And here at CMS, we're working to address their needs as well. For example, CMS has released a report on our Rural Maternal Health Initiative with leadership by CMS OMH, which is seeking to address maternal health disparities for individuals living in rural areas, where you're often likely to find maternity care deserts. More recent reports have also highlighted that pregnant women with disabilities are less likely to get timely prenatal care, and they too are more likely to suffer adverse maternal outcomes. We're focused on that as well. We are trying to be thoughtful and systematic in exploring challenges and opportunities to positively impact birthing people from every group. Although exciting, there is so much work, and we at CMS know that we cannot do this work alone. In alignment with our 5-part action plan, we are also following the activities of our state and local partners, including many of you in this room, to learn and to leverage your efforts at the federal level. We have also been encouraging industry stakeholders to consider key commitments that they can make to improve maternal health outcomes as well. Before I close my remarks, I would be remiss if I did not acknowledge that CMS has had an amazing and inspiring leader for all of our work in this space, our Vice President Kamala Harris. Vice President Harris convened the first ever Maternal Health Day of Action, where she announced a historic call to action to improve health outcomes for parents and infants across the U.S. And with her leadership, the White House released a comprehensive maternity care blueprint describing the whole of government approach to improving maternal health and addressing persistent inequities in maternal health outcomes. And now I'm going to turn to 3 of my fantastic 4 colleagues from CMS who each have deep expertise and experience in maternal health, and they're each leading a critical part of our maternal health strategy. You can find their bio sketches online, but I'd still like each to share a bit about their role here at CMS before they dive deeper on the maternal health work underway at their center. First, we're going to hear from Deputy Jean-Moody Williams from the Center for Clinical Standards and Quality. I did practice that. I normally say CCSQ too. Then we're going to hear from Dr. Aditi Mallick, our Chief Medical Officer at the Center for Medicaid and CHIP Services. And then we're going to hear from Tequila Terry, the Director of the State and Population Health Group at the CMS Innovation Center. Thank you so much.
Thank you, Dora, for those opening remarks, and I'll just follow up on that as she was speaking about the Vice President. And you know, oftentimes we hear this whole of government approach, and sometimes you wonder, well, is that really happening? And I happened to be in the room with the Vice President. The administrator let me tag along, and I actually watched her go from every department to HHS, to Justice, to Housing, to Defense, and say, what are you going to do? What are you going to do? And believe me, nothing was not an option. So it really is a whole of government approach. And within CMS, we really are aligned, as was noted, even as we present ourselves here today, just to reflect that it really, has been noted throughout this conference, together is the way that we will have to ensure improvement. And as was already mentioned, each year with the 700 women that die from pregnancy-related complications, there are also 25,000 who experience severe complications of pregnancy. And many of those occur during hospitalization or immediately after. And much of that is regardless of socioeconomic status, education, as we heard. And as this panel knows, I often say I am the mother of 3 girls who are childbearing age and who have all gone through all the college and masters that I could afford. And yet, when they go into a physician's office to discuss birthing, they're at risk, and they have all the insurance. And the theme that we had at one of our gatherings was, we can do better, and we will do better. Knowing that many of these things occur during hospitalization, it is with this in mind, and really a desire to support a healthcare system that's equitable and that provides high quality maternity care, we launched an initiative through the Inpatient Prospective Payment System, affectionately known as IPPS. And it was through this system that we launched this initiative for participating hospitals to report on a structural maternal measure. And many of you know that in IPPS, if you don't report on the required measures, there is a payment penalty that's associated with it. And if you do, then you avoid the penalty. So then this becomes one incentive of many. But it is with my belief that such incentives they're small and they're not as meaningful, because we have those who already want to do better and who are already trying to promote the best quality of care. And so one of the things that we're incentivizing, however, is the use of evidence-based practices. We know that there are many things that are out there that people try and people do, but we want it to be evidence-based. We also want it, though, to be culturally appropriate. And so it's our job as professionals to try and marry those two things together. And one of the evidence-based practices that we are incentivizing is maternal safety bundles. And these have been proven to be successful, particularly when it comes to preventing hemorrhage or complications such as severe hypertension in pregnancy or C-sections that may not be medically necessary at the time. And they've also been, some of the bundles have been structured to help to incentivize the decrease in disparities among those that are giving birth. IPPS hospitals that are participating in the program are required to report annually on a structural measure. And the measure, what's required is to answer this question. I'm going to read the question to you, and then you can think in your mind, if your facility or if you are a provider, how do you answer this question? Does your hospital or health system participate in a statewide and or national perinatal quality improvement collaborative program aimed at improving maternal outcomes during inpatient labor, delivery, and postpartum care, and has implemented patient safety practices or bundles related to maternal morbidity to address complications, including but not limited to hemorrhage, severe hypertension, preeclampsia, or sepsis? Now, there are three choices to answer that: yes, no, or not applicable. The yes, to answer yes, you have to both participate in the collaborative and implement those practices that the collaborative is bringing forth. So to answer yes, you have to do both. If you answer no, that means that you're not doing one or the other or nothing in that particular area. And we did have several hundred hospitals on this last round that answered no to that question. If you answer in A, what that means is you do not provide labor, delivery, or postpartum service. Now, the NAs were also concerning because when we looked at the map, there were a number of facilities that answered NA in areas where there was a lack of services for delivery. And so the facility's there, but it's not meeting the needs of the community, and no one else is in that particular area. So that is an area that we will look more into. But what we hope to see is the yes answer, because what we expect of a collaborative, and at CCSQ, of course, we're the Quality Improvement Center, is that you're using data, you're trying innovative approaches, you're looking to see if that works, you're sharing best practices with one another, you're sharing what works, what doesn't work, and you're learning together to improve care. And this is what some of the what the collaboratives are doing. And there are a couple that we mentioned, but there are many that are out there. In our rule, you'll note that we talk about the Center for Disease Control and Prevention has a collaborative, as well as HRSA with the AIM collaborative. The California Maternal Quality Care Collaborative is a state-based, and there are many others out there that meet the intent of this measure so that you can answer yes. Now, we've already received 1/4 of data that we posted. It's on, if you look at Hospital Compare, you will see those results for a quarter's worth of data. And many hospitals, as I said, did attest yes, which is great. And we'll be looking and working with those facilities to see how improvement is occurring. There are many others that answered no, and then others that answered NA. Now, the reasons why some may not be participating, as we start to dig into this, we noted, and particularly post-PHE, post-COVID, many facilities no longer or didn't have a quality improvement champion that can help them with the area. Those that had quality improvement champions, many of them left during the period of COVID. And so they don't have the support that they need. There are geographic barriers. There are other barriers that they are facing as they try to implement these models of care. So what we know is that we are going to work to support these facilities. We're looking and working with our sister agencies for technical assistance, and we will continue to monitor. Now, we just completed a full year's worth of data collection. So it started last year. We collected all the data was due, I think, the 15th of May. I know I have a fact checker in the audience, so I hope I'm right there. It was due the middle of May. And we're now in the process of analyzing that data and sharing it with facilities to make sure it's correct. And then we will post it in October. But this time when we post it, we get the privilege of posting the birthing friendly designation. And we unveiled that designation in December. I should have had a picture of it up here, but just go on Google unveiling and you'll see what it looks like. It's an icon that will appear next to the names of the hospitals that meet that structural measure. And so it was very exciting news. And more exciting is not only will we post that, but there are at least 22 health plans that have noted they will honor the birthing friendly designation. And I don't know what icon they'll put up or how they'll do that, but they're using that measure within their health plans. And that number is growing. Now, I have to say that one structural measure is not enough. And we know that. And so we're constantly working, we're getting your ideas, your input. We have 2 electronic clinical quality measures that are in service right now that facilities are reporting on a voluntary basis. That's severe obstetrical complications. They began reporting on that in 2023 for voluntary and to affect the payment period in 2025. In 2024, next year, that measure will become a mandatory electronic clinical quality measure impacting payment in 2026. And so we'll get that data and we'll determine at some point in the future whether that will be added. The other one is the cesarean birth. And this is a measure that assesses the percentage of nulliparous women with a term singleton baby in a vertex position delivered by cesarean section. That also started this year, voluntary, next year, mandatory, impacting payment in 25 and 26. And lastly, we issued an RFI last year to seek comment on what else should we be doing from an oversight perspective as we look at the various tools that we have available to us to make change. And we got a number of responses. So we look forward to the ideas of how we can continue to improve on our designation. We know that you have thoughts. We want to ensure transparency. And at the end of the day, just equity and improving overall maternal health care. So thank you for all you've done and all you will do, because we can do better. Thanks.
Thank you, Jean, and thank you everyone in the room and everyone joining us virtually. As Dora mentioned, my name is Aditi Mallick. I'm the Chief Medical Officer for Medicaid and CHIP. And I'd like to spend the next roughly 10 minutes or so giving you a bit of a landscape view on what we are doing in the Center for Medicaid and CHIP Services to really help combat the crisis that Dora laid out, I think, so eloquently. I will share in the same categories as the CMS Maternal Health Action Plan. And again, those are coverage and access, data, quality, social supports, and workforce. Let me start with coverage and access. If you hear me say nothing else, let it be this. We are deeply committed to ensuring that every American has healthcare coverage. As we unwind from the public health emergency, and we're now past the expiration of the continuous enrollment provisions for Medicaid, states have now resumed the normal operating business of eligibility redeterminations and disenrollments. It is absolutely critical, and priorities 1, 2, 3, 4, 5, that eligible people maintain coverage, whether that be through Medicaid, through the marketplace, through employer-sponsored coverage, or some other form of coverage. And the reason I say that is because it's in the context of a discussion around maternity care, it is absolutely critical for individuals who are pregnant and in the postpartum period to have access to that coverage for themselves and for their children. I also say that as a request to everyone in the room and everyone watching virtually, that we really are in an all hands on deck moment. So please do what you can to get the word out to folks enrolled in Medicaid and CHIP to be checking the mail, updating their contact information, submitting renewal notices, and working with your state Medicaid agency or CHIP agency to help people with the renewal process. We really are at the point of the greatest coverage transition event since the launch of healthcare.gov, and it takes all of us. So again, if you hear me say nothing, please let it be that. But in the spirit of coverage and access, the American Rescue Plan Act created a landmark opportunity for states to extend postpartum coverage to a full 365 days after pregnancy. I say as a mother of 2, including a 10-month-old at home, so I am still in that 1-year postpartum period, incredibly important, not just for peace of mind, but for health. I am excited to share with you today, as of today, that 34 states, including the District of Columbia, have taken up that option to extend postpartum coverage for the full 365 days. You can look up online whether you are tuning in from a state that is not on that list, and we certainly hope that we get to all 51. Relatedly, in the theme of coverage and access, we have dedicated resources specifically to education and outreach campaigns through our Connecting Kids to Coverage campaign that's really designed to help enroll eligible people. And now I mentioned Connecting Kids to Coverage. We released a notice of funding opportunity just last year on the order of about $50 million over a 3-year period, roughly $1.5 million to different organizations to, in addition to help enroll children, to help enroll pregnant individuals and individuals postpartum, again, in recognition of that inextricable link between the health of children and the health of their parents. I also am excited to share with you that all states now have elected some form of dental coverage in pregnancy in the Medicaid program. There is increasingly a recognition of the role that oral health plays in other elements of physical health, and that oral health plays in overall morbidity and mortality with respect to maternal health. So more to come on that front as well. Shifting gears now to data and quality. Hopefully folks in the room are familiar with the Maternal and Infant Health Initiative run through the Center for Medicaid and CHIP Services. If you are not, it's a technical assistance body that really focuses on working elbow to elbow, shoulder to shoulder with our state partners to help improve maternal health outcomes. That group, affectionately known as MIHI, M-I-H-I, MIHI convened an expert work group a few years ago to identify focus areas that would really drive towards improved outcomes in maternal morbidity and mortality. That work group identified 3 areas that we now have ongoing learning collaboratives and peer-to-peer sharing across states. Those areas are increasing the use and quality of postpartum care. 2, increasing the use and quality of infant well-child visits. And the most recent is decreasing low-risk cesarean deliveries. Again, the work group had identified those as 3 key kind of intermediate drivers of maternal morbidity and mortality across the United States. And states opt in to participating in these learning collaboratives, sharing resources, sharing best practices, what's working well in terms of, and not so well in terms of implementation. Related in the data and quality vein, our team also undertook a postpartum quality and equity assessment. And that showed, unfortunately, not surprisingly, disparities in postpartum care, diabetes screening and follow-up, and behavioral health screening and follow-up, to name a few. We're continuing to analyze TMSIS data. And for those that are less familiar with Medicaid, TMSIS data is the specific encounter level data that states send to CMS as an overview of what is happening in the Medicaid program. But that postpartum equity assessment led to a challenge.gov competition for programs that improve postpartum care for, in particular, Black and American Indian and Alaska Native populations, for which 25 winners were announced last summer. We're currently in the judging phase of phase 2 of the competition, where the winners from the first phase had the opportunity to submit evidence of successful scale and impact to spread their programs, and hope to have more information to share on the winners in the coming months. Continuing in that theme of data and quality, for those that are, again, familiar with the Medicaid program, we have a foundational set of quality measures called the Medicaid and CHIP core set. Within that core set, there's an adult core set and a child core set. But across those two, there are 9 measures related to maternal health that sit across both the adult and the pediatric core set. And thanks to an act of Congress some years ago, states are now going to be required to report on those measures beginning in 2024. This is a huge step forward for transparency and quality improvement, because it allows us to have a consistent and apples to apples understanding of things like low birth weight, timely access to prenatal care, and quality of postpartum care across the states and territories. So look out for that. There was a proposed rule that came out last year. That rule is being finalized later this year, again, with mandatory reporting for all states set to begin in 2024. Last thing I want to highlight in the conversation around data and quality is existing quality improvement resources. For those of you that are on the ground doing quality improvement work with state and local partners, please do check out our resources on Medicaid.gov. We currently have 2 QI tools posted so far, with more to come. The first is a driver diagram and a change activities table, and the other is a measurement strategy. Again, really trying to drill down from the strategic level of what is quality improvement to the level of what does it take to implement and actually do this work with partner health systems, with partner community-based organizations, as well as highlights from various webinars in the MIHI program that I mentioned. We are also, in the relatively near future, going to be releasing a toolkit that has a postpartum QI toolkit, again, for states and partners on the ground to really engage in the work of doing quality improvement. Shifting gears now to workforce, I think my colleagues have mentioned the importance of multidisciplinary care teams that are culturally competent and able to meet birthing people and families where they are. We in the Center for Medicaid and CHIP Services in the last year released guidance for states on coverage of doula services in recognition of the fact that not everyone feels comfortable with a physician, not everyone feels seen or heard or listened to, and that there is good data on doulas, certified nurse midwives, and other non-physician practitioners as part of a multidisciplinary care team to help improve patient outcomes. And then I do just, again, want to take the opportunity to plug guidance from a few years ago about the ability for pediatricians to do postpartum depression screening in the pediatrician's office. I'll again reflect on my own personal experience as a relatively new mom. It's pretty easy to miss a postpartum visit, but I have yet to meet a mother that misses visits for her children, particularly in early life, right? You get very busy, but man, the one thing you will schedule your whole life around is visits for your children. And so in recognition, again, that the health of a mother is inextricably linked from the health of a child, that guidance really opened the door for pediatricians to be able to engage new mothers or new parents in postpartum depression screening. And we know that behavioral health, in particular mental health and substance use disorder issues, are huge drivers of maternal mortality and maternal morbidity. So making that linkage to other care settings is really critically important. I'll close with a bit about social supports. Ample evidence showing that clinical care is really just a small fraction of what drives health outcomes, and that the context in which an individual lives, works, worshipped, has much more of an impact, the so-called social determinants of health. And in the Medicaid program, we have made tremendous strides in this administration in the last year, really in advancing coverage of services to address health-related social needs, including for individuals who are pregnant and other high-risk individuals. Things like access to housing supports, access to nutrition supports, medically tailored meals, home-delivered meals, case management around nutrition services and enrollment in other nutrition benefit programs. Again, in recognition of the fact that an individual who is pregnant is not just living in isolation, right? They live in a context, they live in a community, and that it is bettering their health to address the circumstances that are really driving their health. So with that, I will thank you again, and I will turn it over to my colleague, Tequila Terry. Thank you all.
Well, good afternoon, everyone. Come on, we can do better. Good afternoon, everyone. My name's Tequila Terry, and I'm delighted to be with you today. I'm with the CMS Innovation Center. I'm the director for the State and Population Health Group at the Innovation Center. So I get the pleasure of working on a very diverse set of model tests across the country, where we are really working with state governments, where we're working with providers, where we're working with communities to really improve cost and quality and outcomes in health. And most relevant to this conversation, our team has really been thinking about where we can make an impact in maternal health and child health. So to start, for those of you who may not be familiar with the CMS Innovation Center, we were actually established as part of the Affordable Care Act with the goal of testing innovative payment and service delivery projects as a way to lower cost and ultimately preserve or enhance quality. And so our goal is to run tests or research projects or demonstrations, however you want to phrase it, with those goals in mind. And as part of our portfolio, we've prioritized maternal and child health. To date, we have launched 3 models that have focused on driving improvements in access and in quality during pregnancy, during childbirth, the postpartum period, and even as the infant grows into childhood. Maternal health models and our team and our group have been really leading the work to collect evidence on what is working around the country. So I thought I'd spend a little time talking about the models and the learnings that we have captured. To start, we had a model called Strong Start for mothers and newborns, and that ran from 2013 to 2017 with over 211 provider sites around the country, 32 states, the District of Columbia, and Puerto Rico. And the awardees were hospitals, health systems, health plans, community-based providers, and agencies. And the idea is that the folks who were participating in this model were really testing 3 different approaches to maternity care to see what would work best in terms of effects on pregnancy and birth outcomes in Medicaid and CHIP enrollees. So the 3 approaches they looked at were midwife-led birth centers. So think of sort of prenatal care following the midwifery model, wrapped in with social supports, with health education, with services from a peer counselor. The second approach they tested was group prenatal care. And in this approach, they were really looking at a comprehensive prenatal care in a group setting where the participants were focused on getting information about things like nutrition and exercise, stress reduction, family planning, domestic violence, and childbirth preparation. And then finally, the third approach was to focus on a maternity care home approach, where there was a lot of diversity across the model participants, but in general, it was focused on care coordination and psychosocial supports. And the beneficiaries, it's important to note, in this model were very diverse. They had a large number of social and medical challenges that really placed them at risk for experiencing poor birth outcomes. And so as we tested these different approaches, what we found is that birth centers worked. Birth centers in particular all had positive effects, but birth centers really stood out. Women who received prenatal care in the Strong Start birth centers had better birth outcomes. They had lower costs relative to similar Medicaid beneficiaries that were not enrolled in Strong Start. And in particular, we saw rates of preterm birth, low birth weight, and C-sections lower in the birth center participants than the other approaches. Additionally, costs were more than $2,000 lower per mother-infant pairs. And so that tells us a lot about what's working across the country. So that was our first model. That ran, again, from 2013 to 2017. Next, we launched a model called the Maternal Opioid Misuse Model. And this model began just in 2021 and is operating in 7 states. The model is testing the idea of how do you integrate maternity care, behavioral health, addiction treatment, and supports for pregnant or postpartum individuals who are grappling with opioid use disorder. Aditi just talked about that as a significant challenge across the country. And so this model, the MOM model, as we call it, is really focused on what is the model of care that works for these individuals. So the model actually required that pregnant and postpartum birthing parents, along with their infants, again, who are grappling with opioid use disorder, received really a comprehensive set of services delivered in a coordinated and integrated approach to support health and well-being and recovery. And so the requirement was to bring together the behavioral health and the physical health needs. On the physical health side, they got maternity care, they got medication-assisted treatment, primary care, and from a behavioral health standpoint, they received mental health screenings and treatment and other therapies. So it really wraps the birthing person and the infant in these coordinated services. And we found a few things and are still collecting data with this model as we speak, but a few themes are starting to emerge. Number one, social stigma is a barrier. It is a tremendous barrier to the care and to the recovery that persons with OUD are grappling with. And so what we're seeing happen is that the states that are participating in the model recognize this and they're taking action. So they're either introducing or expanding peer recovery services as a way to make sure that we're, one, improving access, but then two, also making sure that we're bringing in people, providers with lived experience. Additionally, they're starting to actually create training programs and implementing formal strategies around education to reduce stigma in the way that care is provided. So addressing that social stigma is critical. The second thing that we identified or are starting to see is that the care coordination services and case management services can be very effective. We have found that the strategies that are being tested in this model have led that have led to the greatest gains are the ones that are actually working closely to coordinate services for these individuals. And in particular, what we're seeing is that when the birthing parents have enhanced access to medication for their OUD, that actually helps them avoid the recurrence of opioid use, particularly during this period where their health is so critical. And what we're hearing from the patients is that patients, when they are a part of this model, they're part of this care structure, their experience is better. They have a more positive labor and postpartum care experience compared with pre-mom model births. And so this is something that is emerging and definitely is an indication of lessons that we can use as we go forward. The third model is a model called the Integrated Care for Kids model. And so both the Strong Start model and the MOM model focused on this idea of how do we get healthy birth outcomes. The INC model, or the Integrated Care for Kids model, contemplates this question of what happens after that child is born and that child develops. What if the child has chronic conditions? What if the child has behavioral health needs, or both? We know that these children face significant morbidity, high healthcare utilization, and premature death. And so that's where INC is really starting. It focuses on really this idea that those children in particular need enhanced services. So the INC model began just last year, delivering services 2022. And there are 7 award recipients across 6 states. The model is designed to improve outcomes for Medicaid enrolled children up to the age of 21 and pregnant adults, with the focus on those that have really complex physical and behavioral health needs and who are identified as needing a broad range of both clinical and health-related social needs or social services. And so the awardees in this model are actually working to conduct early identification, so figuring out who the children are, because remember, at this age, they may be manifesting as school issues if they're having behavioral health issues or even medical issues. So that early identification is a critical part of the work that folks are doing. And then treating them, identifying the services they need and figuring out how to treat and coordinate the care for these children so that the services that they need match what is actually happening in their lives. And our goal is that we want to avoid inpatient services and out-of-home placements. So this idea of early identification and then really wrapping these children around with behavioral health and social services and clinical supports, medical supports. And so what we are starting to see in the INC model is that data infrastructure and sharing is critical. So again, thinking about the children that we're talking about, they're not only needing clinical care services, both the physical and the behavioral health services, but they need school supports, they need food and nutrition, they need child welfare. And so the idea of data and infrastructure and sharing both at a state level and with providers is really important to be able to address the needs. Community engagement is critical. Some of you heard me talk about this in our earlier session. It is really important that we think about how to bring to bear all of the resources that both the clinical care system and communities have. And so this idea of partnership and really jointly prioritizing what needs to happen and identifying the appropriate referral processes, setting up data sharing agreements. That's what the INC awardees are doing, trying to chart the course on how do you do that and how do we set up these partnerships. And then finally, one of the things that is also emerging is that a 2-generation care approach is also critical. It has to be a part of the care design. So this idea of a 2-gen approach really recognizes that health and well-being is really important to the children and their parents or their caretakers, and that those things are inextricably linked. And so the 2-gen approach is a part of what the awardees are doing as they are working on the health of the children and the birthing parents and the family that surround them. And so in closing, I would just like to say that, you know, the Innovation Center has learned a great deal about strategies that can improve equity and access and quality of care and outcomes when it comes to maternal and child health. And we're still learning as we continue to move forward with these models. But what is clear is that, you know, we have data now that shows the effectiveness of birth centers and the importance of including people from the local community and those with lived experiences on the care team. We also understand how important data infrastructure and sharing can be, especially when we're talking about bridging gaps between the clinical and the non-clinical system, the community systems. We have to have the data and the infrastructure to do that, to break down those cross-sector silos and to ensure, even from a continuity of care perspective, that that happens. And then finally, that, you know, again, a 2-gen approach is a holistic approach to family care. And so we are really excited about what we're beginning to see. This will continue to be a priority for us to be working across the spectrum, thinking about, again, prenatal, the birthing process, postpartum, and then children and infants as they continue their development in life. And so I'm delighted to be able to share that information with you. And we look forward to sharing more information as we continue working across the country on these really important initiatives. And with that said, I'll turn it back to Dora.
All right, I think we certainly lived up to our name of the Fantastic Four. I'm just so impressed and continuing to learn more just by listening to my colleagues about the work that they are supporting. We just have a couple minutes left, and so we're going to just, in super true round robin fashion, I'm going to give each of my colleagues 30 seconds, definitely no more than a minute, to say just one thing that's exciting to you that you are looking forward, one little hint of things to come for the audience who have stuck with us for a whole hour in the middle of the afternoon. I'm going to start.
So I think the thing I'm looking forward to are results. I think we were all in the meeting when the administrator says, well, when are we going to see the results? And we said, well, we're getting all these things together. You're going to see results. So I'm looking forward to that.
Okay.
Partnership. I think there is a mass recognition that this is a problem, but I think the thing that most excites me is that it's a red state, blue state, purple state, rural, urban, wealthy, low income. Like, this is an issue that people of all stripes, shapes, sizes care about. And I think that is a key ingredient to results and ongoing success.
Yeah, and I would add, first, I agree with those points. I would add that I'm looking forward to the practical application of the evidence that we are seeing. We now know what are the things that are working. We need to bring more people to the table. We need to have really sort of this idea of bringing people together to leverage all the talents, the resources, the expertise that exists in the both the clinical and the non-clinical settings, and use that to solve this problem. So that is what I'm looking forward to.
And I'll end. What excites me most is that the leadership by this administration and our administrator, Chiquita Brooks-LaSure, she has continued to reinforce, remind us, drive us towards getting the results, reminding us that this has to be a continued priority, and that truly we will be able to do better together. So with that, I'll end, and thank you so much again.